If we can get started, please. Yeah, I have the pleasure of being the third speaker on a very long morning for you, and I realize that, but hoping to be done on time according to the previous schedule. I'm Harry Shamoon. I think you all know by now that you've sort of gotten into that part of the endocrine course, which is really touching on not the rare diseases that some endocrinologists deal with, but the very common disorders, and the most common disorder, thyroid disease, of course, you've heard about, but type 2 diabetes will be coming up tomorrow. So I get to give you a little bit of the overview of the landscape and try to give you some anchor concepts. But for starters, you know, every one of you is going to become some kind of a physician, and all of you will end up having to interact with patients with diabetes. Do me a favor, don't call them diabetics, if you remember, when you get on the ward. People aren't their disease, they're not hypertensives, and they're not canceroids, and they're not diabetics. They're people with diabetes. But the frequency of this disease and how common it is, and the fact that there's disorders linked to diabetes that will engage, you know, surgeons and internists, nephrologists, pediatricians, ER doctors, hospitalists, dermatologists, ophthalmologists, radiologists. You're not going to be able to get away from diabetes. And not to mention, as Dr. Epstein said, the dinner table or the newspaper. So we'll start off by just sort of talking about a little bit of the physiology and remind you that when you look at the course of the day in a group of healthy people, probably medical students, medical student volunteers, eating 3 meals a day, the pattern of plasma glucose shown here as sort of the range in gray is very predictable. These are millimoles per liter, so multiply them by 18, but roughly you start off the day around 70 to 90 milligrams per deciliter. You spend a lot of the day at that glucose level, and certainly overnight, with peaks to about 135 milligrams per deciliter an hour and a half after eating. So this very tight pattern of glucose range is the thing that is disordered in type 2 diabetes, type 1 diabetes, every form of diabetes, stress diabetes, and so on. As we'll talk, of course, this is not enough in terms of diagnosis, and you're certainly not going to track a patient over the course of a day. The other part of this figure shows you the secretory profile of insulin in the plasma. You won't measure this unless you have a very specialized need to or you do research, but we do know that the beta cell controls is the major controller of the plasma glucose excursions. Of course, it peaks with each meal. Insulin signaling has been touched on in other talks. But again, the emphasis here is on the baseline period. Insulin levels are never zero. There's a low amount of baseline insulin throughout the day and night that controls glucose, and you'll see mainly glucose production. So biochemistry last year, you probably remember more of it than I do. Keep remembering it for the boards. But the focus from a clinician perspective, from the perspective of treating patients, is understanding that the liver plays the major role in regulation of glucose homeostasis. And that through pathways that you probably have remembered, new glucose formation, gluconeogenesis, or glycogen breakdown of pre-existing glycogen, glucose is sent into the general circulation. This is under control by insulin and by glucagon, the 2 principal islet hormones. Remember, gluconeogenesis is the formation of 6-carbon glucose from 3-carbon precursors, amino acids, and other substrates that go into glucose. Glucagon promotes gluconeogenesis, insulin inhibits it. On the side of glycogen breakdown, glucagon promotes it and insulin inhibits. So there's a symmetry in this, but that's a very superficial view of the biochemistry. The point is, this is where the glucose is coming from. And contrary to the sort of intuitive concept we have in looking at our daily lives or the lives of our patients, food intake and its promotion of glucose into the circulation is not the direct route by which glucose levels go up. So in the fasting state, and by now I should really use this technical term post-absorptive, meaning after you've eaten, not that when you've been fasting, but 4 hours after eating, pretty much all the hormonal and substrate fluxes have happened, and you're in a post-absorptive state, and you're certainly in a post-absorptive state overnight. You look at this cartoon, and it says this sort of average plasma glucose level of 80 to 90 milligrams per deciliter is maintained by a very tight balance between the production of glucose from the liver and its utilization by tissues. So we've talked a little bit about the glucose production side. On the utilization side, the brain is the major consumer of glucose in the resting state. In non-exercising individuals, 80% of the glucose uptake is neural uptake. There's a small amount that goes to the formed elements of the blood, the white cells and the red cells. Again, these two are not insulin-dependent processes. A small amount of glucose is going into the muscle at steady state, non-exercising muscle. So the glucose utilization side of this equation is very independent of insulin, if you will. Not sure which button I click, but okay, let's see. All right, so Dr. Epstein talked about CNS input into liver glucose production. Maybe he did, maybe he didn't. But there is a pathway that has been elucidated where there is feedback on the liver. But the major feedback, of course, is insulin and glucagon. I include fat in this picture, not because it's a big sink for glucose removal, but because it is one of the sources of substrate in the form of glycerol for gluconeogenesis. So amino acids, lactate, glycerol from muscle and fat are gluconogenic precursors for glucose production. Now in diabetes, really regardless of what form of diabetes, this equation is obviously out of kilter. Plasma glucose, by definition, again in this cartoon, is now shown as 130, so the fasting glucose is elevated. And it's elevated because of unrestrained glucose production, not matched by an increased uptake of glucose in these other tissues. And this is a pretty straightforward story. Insulin, either absolute deficiency, relative deficiency, or insulin inefficiency, resistance, ultimately, at the level of the liver, is manifested by higher rates of glucose flux from gluconeogenesis and glycogen breakdown. And insulin deficiency at the level of the insulin-sensitive tissues on the utilization side, muscle and fat, you would expect this is certainly not going to help. Even though these are small, but these are small contributors to glucose uptake. So insulin deficiency here doesn't have as much of an effect as the lack of insulin's restraining effect on the liver. And since the brain doesn't take up any more glucose in that state, there's really no place for the glucose to go. And it rises, and hence fasting hyperglycemia. So from the clinical perspective, and we'll talk a little bit now about presentation and diagnosis, talk a little bit about treatment. The major forms of diabetes, there's a lot of language out there, and yes, it's Arabic numeral type 1. You'll see it the other way. Used to be called juvenile diabetes, used to be called insulin-dependent diabetes mellitus, IDDM. It's called type 1 diabetes. These are people who develop diabetes, usually below the age of 30. Typically not overweight at the time of diagnosis. In fact, losing weight at the time of diagnosis is a typical presentation. The insulin requirement, that old terminology, insulin dependence, derives from the fact that insulin exogenous insulin is required for life. And when you check that off on the insurance note, insulin requiring insulin-dependent diabetes, it gets a little vague because most patients taking insulin have type 2 diabetes. We'll talk a little bit about that, and Dr. Crandall will emphasize it. But insulin requirement in type 1 diabetes is defined as basically a matter of life and death. These patients are ketosis prone, and a variety of evidence I'll share with you a little bit later suggests this is an autoimmune beta cell destructive process that results in the insulin deficiency. The other and more frequent form of diabetes, type 2, Arabic 2. These are patients who generally present above the age of 30, but that's changing, and we'll talk about pediatric type 2 diabetes in a bit. Most are overweight or obese at the time of onset. Typically, these patients will not present with ketosis or ketoacidosis, and that's a reflection of the fact that their insulin deficiency is not as severe, even though there is some relative insulin deficiency, probably in most forms of type 2 diabetes. But their insulin lack, if you will, or insufficiency, is not due to an autoimmune process in most cases. It's a form of beta cell failure, which Dr. Crandall will talk about, where the islets are not responding as efficiently to the glucose signal as they should, and that insulin resistance in peripheral tissues, particularly muscle, plays a big role in the hyperglycemia. So, 90% of patients in the world with diabetes have type 2. The diagnosis of diabetes, I'm just going to put all of the words on the slide here and not go through them in detail. Let's just start off at the bottom. Any patients who presents with a blood sugar greater than 200 milligrams per deciliter with symptoms of diabetes that you probably know, polyuria, going to the bathroom with a lot of urine formation, polydipsia, thirst, drinking a lot, weight loss, and some rarer sort of clustered presentations. Weight loss, polyuria, and polydipsia, though, are the triad. So a patient who presents that way in the office or in the emergency room with a glucose of over 200 does not need any more tests. That's diabetes. I mean, we can talk about what form and how to treat, but you don't need to do any diagnostic testing. If patients present in a less acute asymptomatic state, then you have to think about doing fasting glucose levels and perhaps an oral glucose tolerance test. So in the fasting state, a glucose of, and you can read this, and it's in the slides, and I'm not going to go through them. But if you take a patient who comes in, they're under stress, it's the first visit, there are reasons why it's recommended that patients have a repeat test under unstressed circumstances to confirm the diagnosis. The vast majority of diagnosis of type 2 diabetes, particularly in the outpatient setting, is made with a fasting. Patient appears in the office, actually usually appears not fasting. Doctor finds a high blood sugar, has them come back a week later for a pre-breakfast blood sugar. It's elevated and confirmed another time. That's sufficient. An oral glucose tolerance test with 75 milligrams glucose is really a research test. It's rarely done in clinical practice, but there are criteria. But the glucose tolerance test is used in gestational diabetes as a required test to see if the mother is developing diabetes. Now, when we talk about type 1 diabetes, one of the features that has always been epidemiologically noticed is different populations have different rates of diabetes. This is a very old slide, and the numbers are probably a little different. But if you look at the Northern Europeans, Canada's in that category for some reason, the rates are higher. There's no question that these are incidence rates of type 1 per 100,000 per year. And these rates are much higher than in China or Cuba or Israel. The U.S. is somewhere in the middle. And there are always exceptions. I mean, one of the funniest exceptions is Sardinia, an island in the Mediterranean, that's about as Italian as you can get, has an incidence of type 1 diabetes as high as the Finns do. So obviously population admixture and genetic background are not entirely geographic. There is that factor to take into account. And if you statistically ask the question, what's the likelihood of running into a patient with type 1 diabetes in the Bronx, given its population admixture, it's lower than if you were in Copenhagen. So inheritance of type 1 diabetes, though, to get a little bit more specific, clearly indicates a genetic component. These percentages, I heard Dr. Epstein talk about 1/3, 2/3 for obesity. They're all estimates, right, based on studies, and in a given patient, that falls apart. But look down here, the lifetime risk in the U.S. among, this line, in the U.S. population, the lifetime risk for type 1 diabetes is about 0.5%. And if you now take a look at identical twins, so if this monozygotic twin has a sibling with type 1 diabetes, the chance of that other one developing diabetes is 50%. So it's roughly 100 times greater than the average population risk. An HLA identical sibling has a much higher rate. Affected sibling, this is still 10 times higher than the population risk. A father with type 1 diabetes actually confers a higher risk of type 1 than a mother with type 1. Both parents affected actually are greater than the sum. So clearly there's an inheritance pattern here, but this 50% gives you an important clue because, as Dr. Crandall will say tomorrow, type 2 diabetes, the one that I said tends to occur in people who are older, has about an 80% concordance risk. So if we're going to play the numbers game, you walk away thinking type 2 diabetes has a bigger genetic component than type 1. And the 50% number here is maybe 40 to 50. So it's clear that the environment and environmental factor or factors plays a role in type 1 diabetes. Looking now at the new cases of type 1 diabetes in the U.S., there was a study, still sort of ongoing, about to look at the rate of new cases of type 1 and type 2 among youth younger than 20 years by race and ethnicity. And so the type 1 diagnosis is in dark blue, the type 2 in light blue. And what you see here is in children less than age 10, the vast majority who present with type 1 diabetes in the dark blue. In the non-Hispanic whites over here, it's clear. Even in the populations, this is non-Hispanic black, Hispanic, Asian and Pacific Islander, and American Indian. The presentation in children less than age 10 is very likely to be type 1 diabetes. But as you look at teenagers, now you begin to see the worldwide epidemic of type 2 diabetes in kids rearing its ugly head. And here we have, for example, in non-Hispanic blacks, 50-50 for the rates of new cases of diabetes, type 1 versus type 2. And among American Indian children, it's a population known to have very high rates, the highest rates of type 2 diabetes. Kids in their teenage years presenting with type 2, with diabetes, will have type 2. So let's talk a little bit about the natural history in terms of the pathogenesis of type 1 diabetes. This is a slide I made up from a very old article in the New England Journal of Medicine. So it's quantitatively shaky, but the concept here is important, which is that this is an evolving disease. And the beauty of this study was that the investigators in Boston at the Joslin Clinic had been following children with type 1 diabetes and wanted to focus on inheritance and genetics. And they thought, gee, the best way to do this is to take kids who have an identical sibling and test the identical twin over the years as well. So they took the blood samples and froze them in a freezer, and 15 years later, when assays became available and they did the study, this is a time course in one such previously unaffected twin who starts off in the red line with a normal fasting glucose, and this is a 100-gram glucose tolerance test. So every year, this twin is coming in with their sibling with diabetes and also being checked out. And so this retrospective study shows that over the years, this previously non-diabetic twin develops diabetes. In fact, fasting glucose criteria today would say this child had diabetes out here in the green line, but it's clearly the case out here in the blue line. And this is a progressive process because these glucose tolerance tests were separated by about 10 years total from the orange and the red up to the blue. And then when they looked at the insulin levels in the same blood samples in this child, and this is the actual time course story, but you can see in the initial glucose tolerance test, the child had a nice insulin peak after oral glucose. These levels of fasting glucose are indeed difficult to distinguish low from normal, so this fuzziness out here is to be expected. But again, you get this picture, right? So over time, now we're going down, this child is developing progressive insulin deficiency and ultimately diabetes. So that background and a lot of animal studies end up in this slide here about the natural history. And I'm not going to go through chapter and verse on the evidence for all of this, but suffice it to say that in this cartoon, we show the total beta cell mass you're born with, 100% of it right here in this part of the figure. Assume a genetic predisposition for type 1 diabetes occurs in these people. We'll talk a little bit later what this environmental trigger might be. It's not established, but with a 50% or 40% concordance rate in twins, there has to be an environmental factor, and that trigger presumably is what kicks off what we know from the animal studies, which this is an inflammatory process of the beta cells. It's termed insulitis because it's an inflammatory process mediated by T cells attacking only the beta cells of the islets of Langerhans. This T cell autoimmunity then is progressive in this cartoon. Following the onset of this immunologic damage, if you will, we can measure humoral autoantibodies. I'll talk a little bit about these. They're epiphenomena probably. They come after the damage, after the trigger and after the damage starts. If you were doing very specialized tests, you might begin to see at this point in time that with a 50% loss of the beta cell mass, this person would have a reduced insulin response to intravenous glucose. You're not going to do that in clinical practice. This is all the silent phase of type 1 diabetes. If you lost your first phase insulin response to a meal, you wouldn't know it, and I wouldn't be able to diagnose it. And in fact, I'm probably not going to do a glucose tolerance test here because you're asymptomatic, you're likely to be young, you're not going to be screened for diabetes unless you're pregnant. So the clinical onset that occurs way down the line after 80% of the beta cells are gone is where we start to see patients. And we may be seeing patients, as I'll talk later on, in an acute state, diabetic ketoacidosis, which is a life-threatening condition. But they still have 20% of their beta cells remaining. So this person who is asymptomatic, doesn't know they have diabetes, going along, has some major stress, usually not just an exam, but an illness. That illness can trigger DKA, a condition in which the underlying insulin deficiency is now insufficient to deal with the metabolic demands of the stress. A person can come in, be treated for diabetes, and when things settle down, they still have 20% of their beta cells remaining. It's going to take another year or 2 years for all those beta cells to be destroyed. So there is a sort of a honeymoon phase after this clinical onset where everything is fine. I suppose that nowadays that's a sexist comment to use the term honeymoon phase. I retract that. You'll see it in the textbooks. So what is the evidence for autoimmunity? You've heard before in this course the association of type 1 diabetes with other autoimmune diseases, particularly thyroid disease. And, you know, it's invariably the case when you ask a patient with what you suspect to be new type 1 diabetes, do you have a family history? They'll tell you two things. One is type 2 diabetes is very common. So yeah, grandpa, I think, had diabetes. But you'll also hear about an aunt or a niece or a nephew, or usually a woman, because autoimmune thyroid disease is more common in women than in men. You'll hear about thyroid disease in the family. That's sort of the typical presentation. Of course, there are subsets of families with severe autoimmune disease where there's no question about the association. This is the typical presentation. It's also been known for about 30 years that that a lot of endocrine diseases, and particularly type 1 diabetes, are associated with certain HLA genes. I mentioned the presence of antibodies, which was a clue when the early clinicians started to measure antibodies in the bloodstream of patients with type 1 diabetes. They said, we figured this out. It's an immune process mediated by these antibodies. And actually, it was studies done here at Einstein by Fleischer and colleagues that showed that in an animal model, the immunity was T-cell mediated. The antibodies in the circulation came after and were sort of biological markers of the damage. And as I said, this insulitis, this inflammation, is present. Now, you're not going to do a biopsy of the pancreas in a healthy person with type 1 diabetes to diagnose insulitis. So most of this evidence comes from animal models, and particularly the NOD mouse, the non-obese diabetic mouse, is a very good model of type 1 diabetes. But there have been, unfortunately, cases where a patient has passed away and the pancreas has been examined post-mortem and inflammation is present. So this is probably true as an underlying pathological defect. This very complicated slide gets more complicated every year I show it. 33 years ago, when I gave this first lecture to an Einstein class on type 1 diabetes, I don't think we had any genes listed. So these get added over time. And you're not going to be expected to remember them. But I just want to give a very sort of superficial perspective that this is also a polygenic disease. We're not going to find a single silver bullet gene for type 1 diabetes. But multiple loci account for this familial clustering of type 1 diabetes. I've mentioned the HLA system, and in the mouse, the major histocompatibility complex. The insulin gene itself on chromosome 11, p15, is implicated as one of the loci, PTPN22, and others. So bottom line in this slide I made probably 4 or 5 months ago, and I would be willing to bet that there's at least 1 or 2 more added. The number of loci is very large when you look at the association with typical type 1 diabetes. The antibodies are interesting not because people believe they're causative, but because as a biomarker they represent tools that can be used in clinical trials, for example, to initiate prevention studies and track the natural course of the disease. So-called islet cell antibodies were the first form detected in the serum. And what's interesting is these antibodies, for the most part, tend to be present in the early stages of type 1 diabetes. When the pancreas has been, when the islet cells have been, when the beta cells have been completely destroyed after several years of type 1 diabetes, as that cartoon showed, the humoral reflection of that in the serum, the antibodies, are no longer present. So in a patient with type 1 diabetes for 20 years, don't bother measuring. If you transplant that patient with an islet cell transplant and you don't give them immune suppression, that type 1 diabetes will recur in that replaced, in those new islets, even if it's coming from a twin. And insulitis will recapitulate the diabetes that happened 20 years earlier. Antibodies will go up and then they'll go away. Insulin autoantibodies are present in the serum of patients. They may be more specific, but the most specific are anti-glutamic acid decarboxylase and one subtype of that are the most specific for type 1 diabetes. So in this summary in blue, the likelihood of developing type 1 diabetes is very high if autoantibodies are present to more than one beta cell antigen. And this becomes important in those studies that I've mentioned about prevention. So if you want to really focus on those children who are going to truly develop type 1 diabetes and you're putting them into a study, then you measure insulin autoantibodies, GAD65, and a subtype of the islet cell antibody called 512, and target those patients to get the greatest yield and see if you can prevent diabetes. But from a clinical perspective, other than confirmatory, measuring islet cell antibodies is generally not recommended. So prevention leads to this notion of resetting the clock, this notion of immune modulation, and it's very complicated. First thing that's complicating this picture is the rates of type 1 diabetes are not stable. Unfortunately, in Finland, the country with the highest rates of diabetes, the rates of type 1 diabetes in children 4 years and under has been going up from 350 per 100,000 population 1980 to 84 to 910. So something is going on in the environment. Now, is this the background pressure of type 2 diabetes, obesity in the mother, et cetera, nobody knows. I may touch on milk. There's a lot of evidence, but it ends up not really confirming the hypothesis that milk protein casein shares certain immunogenic similarities with beta cells, and that maybe children have a higher risk of type 1 if they're exposed to cow's milk early on. Despite the appeal of that hypothesis, it really hasn't been proven. Big studies are still going on. So these environmental factors are largely unknown, and if we don't know them, we can't modify them. So what we can try to modify is intervening at a point where we know that there's an immune process in place that's going to destroy the beta cells, and if we jump in when they're only 50% gone, maybe we can preserve the remainder in terms of residual beta cell function. But again, immunotherapy is complicated. There are some forms of immunotherapy that are presumed to be more targeted to beta cell autoimmunity rather than general autoimmunity. But for the most part, these drugs have side effects, and the more systemic immune suppression you initiate, the greater the risk of diseases like long-term exposure to cancer risk, to the acute effects of some of the drugs, which include, for example, renal damage. And so from a practical perspective in 2013-14, you cannot recommend immunotherapy as a viable way of treating a child with recent onset diabetes unless they're in a clinical trial. There is an ongoing study of oral insulin. Oral insulin might be the safest way, and there is evidence that there may be a small benefit to, insulin taken orally is going to be degraded. But if it has immune suppressive or effects on preventing the beta cell damage, they're going to be small. But the risk then would also be trivial because there is no glucose lowering effect of oral insulin. So back to that cartoon about fasting glucose control, because now we're going to talk a little bit about treatment and the principles underlying it, remembering that it's the restraining effect of insulin. This plus is supposed to indicate when insulin is restraining glucose production, it's going to be preventing this increased production of glucose. I guess this should have been a minus, but you get my point. The effect of insulin in the periphery is less important in this part of the talk. So let's go back in time, and Banting and Best won the Nobel Prize for the discovery of insulin. And This is a phrase taken from Elliot Joslin's textbook on diabetes concerning Leonard Thompson, the first patient treated with insulin in 1922. And it says, on admission, he was poorly nourished, pale. He weighed 65 pounds. His hair was falling out. There was an odor of acetone on the breath. He appeared dull, talked rather slowly, quite willing to lie about all day. This was the state of treatment of diabetes less than a century ago. This child was going to die. Attempts were made to give them lower carbohydrates, and there was some knowledge, obviously, that carbohydrates contribute to the glucose rise, but all of these treatments would fail inevitably, and the child would die. He's given the crude preparation of insulin, and Joslin writes, the boy became brighter, more active, looked better, and said he felt stronger. So this is Leonard Thompson when he first comes to the Joslin clinic, malnourished and near death, really. And 6 years later, I'm sorry, 3 years later, he's in fact a little bit of a chubby kid, and he lives to be in his 70s. So that's the good news. But despite 90 years of progress from this point of this bottle of insulin in the Banting and Best Museum in Toronto, even into the 80s when I started in this field, and now, you know, fancier and easier to use devices like these insulin pumps, this is a condition associated with significant inconvenience, cost, mortality, and morbidity. And I'm going to talk a little bit about the Diabetes Control and Complications trial, only because Einstein was one of the participating centers. And this is one of the landmark studies that, in retrospect, 20 years later, we'd say, well, so you proved that glucose control prevented microvascular complications of diabetes? Everybody knows that. Well, but in the mid-'80s, and certainly when I trained before that, the typical approach to diabetes was you can't do anything for the patient. If you use aggressive therapy, you put them at risk of hypoglycemia in particular, so just keep them out of the hospital. And that's no longer acceptable. This study proved that if you maintain near normal glucose levels, you prevent the devastating complications, and there's evidence from the type 2 study, which Dr. Crandall will talk about, that you may prevent cardiovascular complications as well. So I guess I started giving this talk around here in 1980. A lot of these treatments are here just for completeness sake. Renal transplantation came about, and renal disease is a major complication of diabetes, but it's not a specific treatment for the diabetes per se. The availability of self-monitoring devices for blood glucose testing by the patients, the availability of tracking long-term glucose trends by hemoglobin A1C test, intensive regimens, the availability of recombinant DNA human insulin. The first recombinant product used in patients was insulin. And other forms of therapies we can touch on glibly here, but the armamentarium, the tools you have to treat patients with type 1 diabetes are enormously more sophisticated. And in fact, patients with type 1 diabetes diagnosed in the last 15 years can be told honestly, you're going to have a normal life. It's going to be a pain in the neck, but you're going to have a normal life if you do all of the stuff we're going to talk about. Before we get to that, I have to touch on acute metabolic states in diabetes, because nobody else in the endocrine course will do this. It's complicated, but it's important because I should have labeled the slide mostly life-threatening complications of acute decompensation. So we'll touch on diabetic ketoacidosis here, a bit on hyperosmolar coma, and not talk about these other conditions, which I think you've touched on in your other parts of the pathophysiology course. But this crude Venn diagram thing here basically is talking about extreme hyperglycemic conditions, conditions associated with ketosis, and conditions associated with acidosis, and the overlap, which is diabetic ketoacidosis, a condition characterized by all three. So you can have metabolic acidotic states, such as lactic acidosis, hyperchloremic, salicylate aspirin overdose, and others where you don't have the other features. You can have ketotic states ranging from normal, which is what those of you who are going to fast on Friday night will have by 4 o'clock in the afternoon on Saturday, which is a mildly ketotic state, to much more severe ketosis with prolonged starvation, to alcoholic ketosis. But these states are not associated with the other features of diabetic ketoacidosis. So ketoacidosis, of course, then is the hallmark presentation for a condition in which hyperglycemia, ketosis, and acidosis coexist. You probably can't read all of the stuff on this slide, which is not intended to be a detail slide, but suffice it to say that insufficient or absent insulin is going to start this cascade. It's going to start the cascade by allowing the fat cell to, or unrestraining the fat cell's release of glycerol and free fatty acids into the circulation, of removing the restraint on hormones such as glucagon, paracrine effects, but also directly affecting the liver to increase glucose production, and on muscle cells by allowing the release of amino acids in greater amounts. So the flux of amino acids leading to increased glucose production, the flux of fatty acids and glycerol leading to beta oxidation in the liver to ketone bodies, starts this metabolic cascade which we call ketoacidosis. As the glucose levels rise in the circulation, they reach the threshold at which the renal reabsorptive capacity is exceeded, and the patient starts to have polyuria and ultimately potentially dehydration if they don't consume increased amounts of fluids to compensate. So this fluid part of the equation is really important because both diabetic ketoacidosis and the hyperosmolar states usually associated with type 2 diabetes are as much due to the dehydration as they are to the metabolic condition of insulin deficiency and glucose excess. So looking at this part of the diagram in red, the glycosuria in hyperglycemic states, where the glucose level exceeds about 180 milligrams per deciliter in adults, begins to pull water with it. There's an osmotic diuresis. This loss of water and electrolytes is part of the metabolic syndrome that results. Dehydration, changes in mental status, decreased fluid intake, perhaps because of the change in mental status, become a vicious cycle. Impaired renal function because of poor perfusion due to the volume depletion, part of the vicious cycle. And you end up either with DKA, where there's severe insulin deficiency, or a hyperosmolar hyperglycemic state where the glucose level can be 1,000 or 1,500 or 2,000 milligrams percent. And these patients, both patients can present with obtundation, coma that can go on to death. So in the big picture of metabolic emergencies, then DKA and hyperosmolar hyperglycemic states are here in blue, and some of the comparators on the slide are, range from starvation or a high fat intake, which is probably not something you're going to be concerned about. But you will see patients with lactic acidosis due to other conditions or alcoholic ketosis. And it's important then to look at some of the features here that can differentiate these conditions. So clearly the pH, which will be normal under normal physiological conditions of fasting. If you make insulin and all you're doing is fasting, even for 3 days, you will not become acidemic. So your pH will remain normal even if you've got elevated plasma ketones, urine ketones, and so on. If you look at the patient with DKA, of course, their pH will be reduced. In hyperosmolar state, by definition, without DKA, the pH is normal. And in these acidemic states, to varying degree, they're defined by having prevailing acidosis. Plasma glucose, of course, becomes a differentiating feature. It's elevated in DKA and very, very much elevated in hyperosmolar hyperglycemic states. The plasma ketone is a very important differentiator. You can actually do that quickly at the bedside, although these days we don't do too many bedside tests, with a urine ketone. But patients with type 1 diabetes are instructed to have ketone sticks at home as well. And if they're ill, if they're vomiting and not able to drink, to call us to test their blood, which of course will be helpful for the glucose levels, but to also test their urine and see if they're ketotic. If they're not ketotic in the urine, it's not as much of an emergency, but even then, they're going to be advised on taking extra insulin, drinking fluids, if they can, getting antiemetics to be able to drink fluids and resolving the DKA, if you will, the mild DKA at home. But you'll see a lot of DKA in the hospital, and you'll have to work to differentiate at the time of presentation whether the patient had diabetes, big factor, right, in the history. But if they come in obtunded with no family members, you're not going to know. A treatment of DKA, this is not the Washington manual version. You'll have plenty of time to do that. But I just want to touch on the fact that IV fluids are a very important part of the treatment. In fact, you start IV fluids before you make any decisions about anything else. Of course, insulin infusion comes soon after in low doses. Because fluid depletion is almost invariably present in these patients. You look for underlying causes. Infection is a big one, but frequently these patients will not present with a focal infection. You have to monitor electrolytes because most of these patients will be hypokalemic, and this can lead to sudden death. You have to replace potassium, fluids, and insulin almost always, and sometimes you have to add antibiotics if you know of an infection or suspect one, and sometimes you have to actually treat the acidosis with bicarb and hypophosphatemia with phosphate. These two carry risks, the treatment with bicarbonate and phosphate, so there are very special conditions under which you would use replacement. I know I'm going fast, but chronic monitoring of glucose levels. This is a lifesaver test. In the mid-80s, this test first became available. Work done by Michael Brownlee at this institution and others had proven that hemoglobin, like many other proteins, a fraction of hemoglobin gets glycosylated in vivo. And that glucose then becomes stuck to the protein, changes its behavior on electrophoresis. Interesting observation. But it turns out that because this is irreversible, the change in pattern of that fraction of hemoglobin becomes a way of tracking the prevailing glucose levels for the previous month or two. And so this test has now really provided us with the tool we need to monitor chronic therapy. Intensive regimens are used almost invariably now to treat patients with type 1 diabetes. These attempt to mimic that pattern of insulin that I showed in the first slide. Of course, they don't do it as efficiently because the insulin, even with a pump, is being delivered subcutaneously. And subcutaneous absorption is very different and much less smooth than if insulin were going in directly into the portal vein, as is the case with the normal beta cell in the islets of Langerhans. Testing the glucose frequently during the day allows the patient to make adjustments, but there is no reliable form of feedback-controlled insulin secretion yet in clinical practice. So if you had feedback-controlled insulin secretion, like your own pancreas islet cells, and this is the insulin secretory pattern, you would make these adjustments unconsciously and rapidly at the level of glucose production and the metabolic milieu. In the absence of feedback-controlled insulin secretion, you're relying on a drop of blood taken at the most 6 or 7 times a day, such as in women who are pregnant or in patients on intensive therapy, 4 to 6 times a day. That's not minute-by-minute feedback control. It is actually pretty remarkable that without that minute-to-minute feedback control, we can maintain glucose levels near normal. Even in before the advent of specialized analog insulins, which Dr. Crandall will talk about, the DCCT slide here, talking about hypoglycemia, this was a study to compare intensive therapy to standard therapy. And intensive therapy involved using longer-acting and short-acting insulins. We now have much better longer-acting insulins and much faster fast-acting insulins than we did in the DCCT days. But even then, we were able to maintain a separation between the two treatment groups. What this slide shows, though, that glycemic control, intensive therapy with insulin, carries a risk, a known risk of severe hypoglycemia. And this is the rate of severe hypoglycemic episodes on the left hand, on the y-axis, in relation to the average hemoglobin A1C maintained by that patient in the course of the 7.5 years in the DCCT. And the closer to normal, normal range of an A1C is about 6, the closer to normal these patients were, the higher the risk of the severe hypoglycemic episodes. Severe hypoglycemia is defined not by how bad the patient feels, but clinically, very simply. It's a condition in which the patient has a low glucose sufficient to impair their ability to treat themselves. They may be unconscious sometimes. They may have had intravenous glucose in an emergency room. They may have received glucagon from a family member to reverse the hypoglycemia. Those are all associated, if you will, with a definition of severe hypoglycemia. But just feeling hypoglycemic and having the systemic response of the adrenaline response, particularly the autonomic response, is not the definition. So the definition is impairment in neurological function sufficient that the patient can't help her or himself. I'm not going to talk a lot about the counterregulation for lack of time, other than to say that with insulin impairing the release of, so if too little insulin allows the glucose production of the liver to go up, too much insulin suppresses the production of glucose from the liver. This suppression triggers brain and other receptors to stimulate particularly glucagon from the islets of Langerhans, the alpha cells, and the adrenal medulla secretes epinephrine, the two acutely released hormones that counteract the effect of excess insulin during hypoglycemia. Now, what's important to understand is that if we do studies in healthy medical students and ask what is the glucose threshold in normal people for releasing hormones, for the protective defense mechanisms to come into play, what we see is that, excuse me, that glucagon, epinephrine are triggered at around 3.5, 65 milligrams per deciliter. To do the math quickly for you, this is another millimolar slide. Oh, this is the milligram per deciliter down here. So this is your threshold for triggering these acute emergency hormones. The growth hormone and cortisol don't play as much of a role there on the slide. But what's really important is these defense mechanisms come into play way before you see cognitive impairment below around 50 milligrams per deciliter, where you can either show in studies that patients can't do computer-based tests as effectively, or in real life where the patient might be wandering off the highway when they're driving. So cognitive function is highly protected by these defense mechanisms. The problem is that there are factors that change counterregulation. So the patient with type 1 diabetes doesn't just have the risk of using insulin, a hormone that can lower the glucose, but has the additional risk of impaired defense mechanisms for sure, and some of these other things. So factors interfering with counterregulation, changes in the sensitivity to insulin have to be taken into account. If the patient exercised heavily, especially if they're not used to exercise, the next 8 or 10 hours or 12 hours, they're at increased risk of hypoglycemia because their body has become sensitive to the same dose of insulin they were taking before. Changes in drug metabolism, obviously not eating, and weight loss, potentially other medical conditions. But these associations with severe hypoglycemia, all of which may, this is the definition, temporarily disabling hypoglycemia with usually neurological symptoms, and the patient requires assistance such as oral carbohydrate, IM glucagon, or IV glucose given by someone else. That's the definition. But these other factors, the first one is what we've studied and others have shown and is really important, which is the defense mechanisms of glucagon and epinephrine, which you would think would be needed in type 1 diabetes more so, are defective. There's an old study, and there's lots of much better studies, but if we lower the plasma glucose level to the same level in people with type 1 diabetes in this purple color compared to non-diabetic controls in blue, what you see is the patients with type 1 diabetes secrete less glucagon and less epinephrine. Their glucose production doesn't rebound as well. They're at risk of more severe and more prolonged hypoglycemia. So this conundrum, I mean, there's a lot of physiology I'm not going to go into, but this clinical feature is important to remember. In patients with type 1 diabetes, you're not dealing with an intact defense mechanism to help you. You have to be extra careful. Despite that, patients can have normal A1Cs and live normal lives. Type 1 diabetes is not just a disease of childhood. Adults get it, so it's not juvenile diabetes. Blood control matters. Dr. Crandall will tell you by quantitating how much it matters tomorrow. This is a disease that requires a team, a nurse educator, a nutritionist. Physicians alone can't achieve metabolic control for their patients, and the patient is the most important member of that team. You have to measure the A1C 4 times a year and monitor the patient's average and overall trends, not just that patient monitoring their own glucoses daily. And hypoglycemia makes it difficult but not impossible to achieve tight blood glucose control. So that's it. Thank you. I'll stay up here for another